Welcome to the Rehab and Performance Lab, the MedBridge podcast where we dive into the world of orthopedics and sports. We're here to unpack the big topics, offering you practical insights and valuable tips from some of the most inspiring professionals in our field. Don't forget to visit medbridge.com to get your continuing education credit for this episode, plus access bonus resources. Hey everyone, welcome to the podcast. I'm Phil Plisky, your host. I'm a professor, I'm the founder of Coaches Club at philplisky.com, and a performance systems consultant in professional sports. Being a physical therapist, an athletic trainer, and strength and conditioning coach, we like to come at this from multiple angles. We want to provide research-based updates and the latest evidence, but more importantly, I think we want this to be practical and applicable for you. So I'm looking forward to our topic today. Do you know the top 5 orthopedic rehab provider updates that everyone needs to know? And I'm joined by Dr. Eric Robertson, who's an expert in the area of manual and musculoskeletal physical therapy, as well as a hybrid and distance-based education expert. Welcome to the podcast, Eric.
Thanks, Phil. Appreciate the opportunity to be here.
Fantastic. Can you just get us started by telling us a little bit about yourself?
Yeah, I mean, that's a dangerous question. I could keep going for a while, but, we'll start. I'm a physical therapist. I've been a physical therapist for about 25 years, and I've been in education for a while. In education, I teach some orthopedics and I teach some pharmacology, but my main job is that I build distance-based programs for different universities. So that's keeps me busy, a lot of different moving parts there. I have a lot of experience in residency and fellowship education as well. And as part of that, I'm also the curator of the OCS exam prep program for MedBridge. And then finally, another important side of me, I kind of have like a second professional side, is that I'm a visual artist. And so I'm a photographic artist, and I exhibit and go around and do some stuff with the fine arts as well.
Fantastic. Well, a true Renaissance man, a lot of different hats, a lot of different areas. That's really incredible. You know, one of the things I hear in that, though, is a common theme of all the different things you have to do. You need to be both kept up to date on the research in all these different areas, as well as have a good appreciation for contemporary clinical practice. So I think this is going to be a great discussion because of that expertise. So that's awesome. So you help and maintain and curate the OCS prep program. And, as I look at these programs, we have a lot of different programs out there, prep programs in sports and neuro. You do this. Are these programs just for people who are going to take the orthopedic sports specialist exam, or is it beyond that? Like, is there more applicability of these programs?
Yeah, that's a great question. And the thing I think about with preparing for taking a specialty board exam or any advanced certification, you're really, the end goal is the patient, right? Like, you want to be able to improve practice. And sometimes the vector for that is through a certification and you get the acknowledgement. But really the value in it is this inherent intrinsic professional development process that you go through. And so to that extent, I think, I feel most satisfied when somebody has taken the prep course and says, boy, I really learned stuff. Like, this actually changed my practice. Because sometimes that's a surprise to people. Right.
They're so almost focused. You separate out kind of studying for an exam and maybe the true end goal. I really love that concept.
Yeah. So I think this is one of the secret tricks, is because the exam itself is designed to cover contemporary practice. And we always update this course and the series and the content in it. If you're engaging in it, then you're really like exposing yourself to all of contemporary orthopedic musculoskeletal practice. And so in that sense, the answer to your question is absolutely. It extends, beyond just people taking this exam. It extends to any practitioner, anybody who has a curiosity, athletic trainers. It would go beyond just these people sitting for the orthopedic specialty exam.
That's fantastic. One of the things that I've really realized over a profession, in being in this profession for a few years, there's two big things that to me help solve burnout, help have an ideal career. And one is achieving your goals, your own goals. The second, though, is actually more important than the first. It's helping others achieve their goals. And so I hear that in exactly what you're saying, in that, what you said is when people, tell you someone was helped by the prep program, they helped a patient, right? So if we can, reframe what we're doing, we're killing kind of two birds with one stone. We're saying, hey, my goal is to be an expert. My goal is to advance. My goal is to take the OCS or take an additional certification. But the ultimate goal is helping someone else achieve their goals, which is our patients. And so I love that perspective.
Yeah, I think the like a specialty certification is sort of the carrot at the end of the pathway, right? Like it's your goal that you're going to, but it doesn't need to be the carrot, right? The really it's that intrinsic, like, I know a little bit more, I feel a little bit more comfortable in clinic today because I use this tool to expose myself to some research, and that's really what I think today should be about, which is running down some of the highlights. There's been some recent updates, and there's been there's always new clinical practice guidelines being developed. And so that's where we end up today with our topic. Like, what are the things?
All right. Well, let's dive into that. So you're saying that what is the latest? What is, what do we need to be up to date on? And maybe we can also dive in. How do we go about that? But in orthopedics in general, and what I love about the topic of orthopedics, if anybody knows about board specialty, orthopedics and sports have a 60% overlap in their content areas, right? And so whether you're a physical therapist or an athletic trainer, whether you see mainly athletes or, mainly orthopedic patients, both, all of this is really based in orthopedics. So can you give us some highlights on the research from that?
Yeah. So, it's also a challenge, right? Because these are both like enormous fields, and you could lose yourself a little bit. And so, I think you mentioned it really briefly, like, how do you stay up to date? And, for me, one of the most efficient ways to stay up to date is to engage in the clinical practice guideline collection, in particular, that from the Academy of Orthopedic PT, right? They always have their new guidelines, and they've existed. I think probably the first one is 2008. And so some of them have been through several iterations. I think the plantar heel pain and plantar fasciitis one is in its third revision, which is really cool. And so if you can consume those and be aware of when there's updates and what the summary is, then I think you're off to a good start. And so that's sort of what I want to talk about today. Are there some of those more recent guidelines that have come out? And in particular, I want to talk about the hamstring guideline, the radial fracture guideline, a non-arthritic hip pain, and then also that plantar heel pain. I think there's some cool updates there. There's also a couple little ancillary things. I think I said 5 updates, but maybe we'll do 7.
Okay,
maybe we'll do 7.
Maybe we'll just even get into the top 10. Everybody loves a top 10 list. So David Letterman was famous for that. So maybe it'll be Eric's top 10 updates now.
We could get there.
That's awesome.
Yeah, one of the first things that came out was kind of a new one. It's a guideline that's under development. And so I think it's a really interesting thing to talk about. It's a paper that is published ahead of print right now in JOSPT, so you can find it online. It's from Furland et al. And one of the authors there is Joe Godges, who, if you know anything about the behind the scenes for the guidelines, Joe Godges was sort of the engine that really drove this for a long time. And so, I had a chance to speak with him about this paper that came out. And the paper is basically what are common conditions that physical therapists see, and what are common conditions that should require referral. And it's a really interesting paper. You look through it, and at first you're like, okay, these are things that
why do we need a list? Why do we need a list of what rehab providers see? Like, so what?
Exactly. Yeah. Why do we need that list? And the list is part of a process to develop a new guideline. And so what we see is when people have these conditions that either coexist, they're not, physical therapist specific conditions. So, medical or surgical conditions that sort of coexist with orthopedic conditions or masquerade as orthopedic conditions. Right. There's a little inconsistency in practice, right? When do I refer this one? It's right. A nerve entrapment. How do I refer this? What is the criteria that I need to refer these things? And if you look at our practice and our literature, that's a little bit of a gap. And so they've developed this paper that outlines and describes these common conditions as sort of a foundational step to produce a guideline that is going to be criteria for referral. And so that's a guideline that's under development. And I think it's nice to look at those conditions. I think there's 37 different conditions that are serious medical conditions that require referral. And boy, doesn't that just sort of like, if you're preparing for an exam or if you're thinking about,
I see practice, this,
it just like cones you down.
Yeah, from not only an advanced perspective or advancing your career perspective, but I look at even some of your work and what you do, entry level practice. probably should revolve around that. And believe it or not, that's where advanced practice specialty exams are developed from. That's where entry-level practice exams are developed from. And ultimately, if we kind of go back and keep in mind, what is our goal with an exam? Our goal with an exam is not to just get a feather in our cap. It is to say, I have this competency. It also motivates us, right? It motivates us to kind of look in a little bit deeper. We might have the best intentions of keeping up. We might have the best intentions of saying, oh yeah, I'm going to always stay on top of things. The exam helps us do that. So, all right, so we now have this group of diagnoses that, hey, and I love the idea of things we need to refer, because that's probably our number one thing is, right, do no harm.
Sure.
And knowing when to refer is there. What else is there?
So another interesting update before we dive into these clinical practice guidelines is an international position statement. And if you approach it one way, you'll find that the position statement was authored by Anita Gross and a few colleagues from the International Federation of Manual and Musculoskeletal Physical Therapy. Or there's another paper that's out that sort of was the Delphi study that underlined that position statement. And that position statement is about the use of manual therapy and manipulation in infants and children.
Oh, okay.
Right. So this is a really interesting, controversial topic.
Right.
And, this group did a lot of hard work, interviewed a lot of people, really got a consensus statement, and they came to very key consensus statements that help clinicians navigate through when it's okay to use manual therapy and when it's not. And this guideline, that the statement that they have, goes all the way from infants, like under 2 years old, all the way up to late adolescence. And so that's a really interesting position statement. So, it's too probably broad and nuanced to go through all those things right here. But what I will say is they have a really clear statement that, spinal manipulation is not appropriate for an infant, right? Anybody under 2 years old. And you see it, you see videos and TikToks, and you're right. Like, you instinctively cringe, but where's the guideline about that? Now we have it.
So we're gonna solve our ear infection and things like that from manipulation of infants. But can you dive in a little bit? I think maybe intuitively, or there's something in us as rehab providers that say, man, I don't feel really great about that in general. But does the guideline indicate, like, the little bit more of the why behind that, or okay, we shouldn't, it's not like touching a stove where I know I shouldn't, put my hand on a stove because I'm going to get burned. Where does that stand on there?
Yeah, so it's about skeletal maturity, and it's about inherent mobility, right?
Okay.
And so, children bounce, right? They're kind of built to fall down a lot.
Right.
And part of that is that there's a lot of resiliency in their system, and they can move, and there's a lot of play. It's very uncommon to find outside of a neurologic injury a child that has a lot of stiffness in their spine, right? And so those two things combined, like the robustness of the bone structure, the robustness of the ligament structure, it just isn't a good match for a lot of manual therapy techniques. And it's not necessarily a good match, but there's a lot of other things that you could do in the meantime. As the child gets older and that skeletal maturity happens, you see that position statement change with it. And so that by the time you're in adolescence, yeah, it's okay. It's appropriate to do those things.
That's awesome. That's great. So what else is there?
All right. So, I think now let's get into some of these clinical guidelines. And the first thing I want to say about clinical guidelines is, I always recommend people go there. And so they'll go to orthopt.org and they'll look at the clinical practice guideline button. They'll open it up. They'll hit the document. They're feeling great about everything. They open this clinical practice guideline and it's 87 pages.
Yeah, right.
And then we hit the wall. Then we're stopped. And so I think the first thing is, like, how do you consume an 87-page document in a way that's clinically useful, or in a way that's possible, right? Because you're a busy clinician, you're in the clinic, like, you're barely getting lunch. I don't have 87 pages time.
Absolutely.
So I do it a few ways, right? The first thing is I imagine it to be like a sculpture, right? I'm not going to make a sculpture in a day. I'm going to consume little bits. I'm going to do a little bit here, a little bit there. My masterpiece is going to take some time to consume. So that's the first thing, is set your own expectations as, like, it's unrealistic to read this. Okay.
Right.
The second thing is they all are really handy, and they start out with the summary of recommendations. And so the summary of recommendations page is 1 page or 2 pages. And it's very convenient, and it has the strength of evidence. So you'll say, like, A, strong evidence, and it'll say manual therapy, and it'll tell you what to do and it'll give you just the rundown there. All right. And so what I like to do is start with that 1 or 2 pages. That's all I need to do. And I just read it and that's it. I'm done. I don't go any further.
Can we pause there for a second? Because I think that's an exceptionally important point that maybe is a little bit lost on us as rehab providers, because we're taught in school, like it's beat into our heads, don't just read the abstract because there's so much more, you don't know if it's actually a good study or not by reading the abstract. But what you're saying, though, is the clinical practice guidelines are different for a couple reasons, I think. Number one is reading something is better than not, don't let perfection be the enemy of better or good, right? So reading the summaries is way better than not doing anything at all. But secondly, there's a panel of experts that this has been vetted through in a very thorough way that really a lot of junk is not going to get in there. Is that fair?
Yeah, that's a totally accurate statement. I was on the author group for the 2017 NEC clinical practice guideline revision. And that was the first guideline at the time that we were able to use all high quality systematic reviews, and reviews of reviews. And so there was actually no primary RCTs in that at all. So first off, you're looking so broad that you're able to pull really high quality processed evidence to begin with. Then you have this group of like really nerdy academics that are, entrenched in this field. And so that's a second level.
They've all read the randomized control trials and the case control. They've read everything already. And then you have the systematic reviews, which then have processed all of those.
Yeah. As a matter of fact, the systematic reviews, we sat there in a spreadsheet for many months and we would look at the systematic review, record its conclusion, but then we would evaluate the source articles for it to make sure that we still wanted to include it, right? So we were in there. But then once it's written, it goes through a review at the local academy level. It goes to an international panel for review. You're getting a document that's one of the benefits of clinical practice guidelines. Like this is processed evidence, right? You don't have to read this clinical practice guideline and say like, oh, they didn't have
they probably missed
there was
about
no control
10 studies.
group.
They missed. So abstract in this point or summary is a very awesome place to start, and you actually can get a ton of information out there.
Yeah, you can get a ton of information, and that's where I start with just that abstract, and then I let my curiosity guide me, and that's where I get more to this like sculpture, take a bite every day, like every couple days, Okay, so it said a thing about intrinsic foot muscle strengthening. Well, is there more about that? And so then I'll scroll down in that document and I'll read that section, right? And they do a really good job about that, of like talking about all the specific details. So as much as you want to dig into the details, it's there. But have realistic expectations. Just start with that summary page, get some stuff, and then let your curiosity or let your patient load or, let whatever if you're studying for the exam, let your performance on test questions, let those things guide how you consume the rest of it.
That's awesome. All right. So can we go through some examples of particular CPGs that maybe have some have some new information or have some information that may be surprising or interesting to orthopedic providers?
Yeah, great. So, the first one is the guideline for non-arthritic hip pain. And that one is really interesting because you say, okay, non-arthritic hip pain, like what is that?
Mm-hmm.
And boy, that's handy because that's where the guideline starts. And if you go through the description of the condition and the clinical course, that guideline is extremely useful to define all of the different types of non-arthritic hip pain that might fall under that guideline. So you're talking about things from, different like acetabular versions and FAI and the terminology between FAI and FAIS, where S adds the syndrome, right? So you could have this, acetabular impingement on imaging and not correlated with clinical signs and symptoms, which happens in up to like a quarter of people. Trying to get that terminology straight, talking about instability at the hip. And so it really goes through all of that terminology, which is, I think, really fantastic as just a real good background and a real good, like, get you up to speed, because this is a particular area where a lot of research has been developed in the last like decade and a half.
For sure. Yeah. When you and I started practicing, it was pretty new to we did not have a lot of nuance in hip articular problems. There wasn't much nuance there. It was kind of hip pain and greater trochanteric bursitis and OA, and
that was it.
Those are your big buckets.
Yeah, maybe if you got lucky or a real advanced course, you could get a loose body in there, right?
Right,
But
right.
yeah.
Yeah, exactly. Exactly.
So this is good, and it talks about some specific tests for hip stability. It describes like the prone apprehension and relocation test for the hip, which a lot of people are familiar with the shoulder. So that's a good one. And then the other thing that's interesting is, like low back pain and like cervical pain, and this is something that we're seeing as a pattern over and over in musculoskeletal care. You see risk factors and predictors of prognosis when you look at things like depression, anxiety, self-efficacy, kinesiophobia. And so people with hip conditions should be evaluated for all these other constructs that, sometimes you think about it as purely like a low back pain thing because that's where the evidence
Right,
started, and it's
right.
not, right? So these constructs that predict overall health status are present in all of these things.
That's incredible. Yeah. So that's interesting. And that's the neat thing about looking at the CPGs overall too, right? Rather than just even as an individual practice guideline for a particular body region, you do start to notice some of the trends, some of the, things that overlap, and you go, oh, wait a second, I know I should be looking at other areas of the body. I know I should be looking at other systems in the body. I know I should be looking at the psychological components of things, but man, this now maybe gives me some layout for my general exam or my exam in general.
Yeah, and sometimes you have to hear it a lot of times, right? And before you really start like
Right.
evaluating it in every patient, and especially like having gone through like a Maitland training program myself, where you're assessing like irritability, and when I learned this, it was tissue irritability,
Right.
right? And now it's not. Now it's like a broader sense of irritability, which is includes all these non-tissue specific factors like anxiety, for example.
That's incredible. Yeah, it's certainly, and what's interesting about that has been a theme on this podcast. No matter what expert we bring in, we want to talk specifically about manual therapy, or we want to talk about neuroscience of pain. It always is like, yes, let's talk about that. But do you understand it's a broader issue, and that's great to have the CPGs go along right with that.
Yeah, and that's a good transition to the next one I want to bring up a couple points about, which is the distal radial fracture, CPG. And this is, we talked about sports and orthopedics having overlap. To me, this one is a little bit of an overlap for geriatric exam and that specialty, because that's who gets distal radius fractures primarily. And I will say primarily because I have my own distal radial.
See it there. Yeah.
So, one of the interesting points of this one is that it has risk factors for poor prognosis. And they do a specific mention. There's two different evidence statements. And one is risk factor for poor functional outcome, and one is a risk factor for persistent pain. And I thought it was really interesting that it's different criteria that fit into each of those. So, for example, risk factors for poor functional outcome is age, over 65, high baseline levels of disability, third-party payer, and comorbid psychosocial factors like depression. Okay, so age and disability ring as like a thing I can remember for that one.
Right.
But then the risk factors for persistent pain are female gender, high baseline pain, and then also depression.
Interesting. So we have an overlap there.
With the depression is the overlap, but the other two are really different, which is interesting. And the female gender is an important one because I think females get or experience distal radius fractures about 6 times more often than men do. So that's an important thing there. The other thing that guideline talks about is fall risk screening. And so that's something where, you're definitely getting into more of like this geriatric thing, but you're seeing a musculoskeletal condition and then you're immediately saying, well, they might have this because they fell.
Well, and that's, and isn't our primary job as rehabilitation providers to look at the whole person and say there's risk factors. I always give the analogy that when you go in to your physician for a sinus infection, you're going to get your blood pressure and heart rate taken. Not necessarily because it's directly related to what's going on. Certainly they want to know that might have a factor, but it's also just a risk factor. It's a benchmark for your overall health. And certainly as rehab providers, fall risk is right in there. And now we know someone who most likely has an increased risk just because of the outcome they had.
Right. And falls, a previous history of fall is a predictor of another fall. So, there you go.
Right.
So I think that's an interesting guideline. It exposes some things, and I remember when I first saw that one come out, I'm like, distal radius fracture?
Right.
Okay.
Yeah.
But yeah, it's actually a lot more fascinating than you think once you dig into it. So,
That's
so
incredible.
thankful to those authors for making that one.
For sure.
I guess related to a previous history of something predicts a future something. Aside from being a bad driver, right? You're a bad driver once, you're kind of always a bad driver. But
we got to talk about the research on that. Wasn't it something like 80% of people believe they're a better than average driver, which is, statistically impossible, right?
Except for you and I, but that's
right,
okay.
Exactly.
Right?
Yeah. I'm there. So yeah, I'm an average driver, I will say.
So, but what I'm talking about now is hamstring injury.
Okay.
Right. And so, and this is something you probably know about, a little bit more than me, even because I feel like this lives in the sports world. But this is a guideline in the orthopedic section too. So, one of the things that I think is fascinating about hamstring injury is that if you look at risk factors for hamstring injury, weakness of the hamstring isn't really up there in the predictive factors. Right.
All right. Let's dive into that.
Yeah. So if you look at this, there's a paper in particular that this clinical practice guideline cites by Green et al. And that paper found hamstring weakness to be only a weak predictor of hamstring injury.
So not a predictor, but a weak predictor. And that's important though. So it's not the most important factor.
Right. And so there was a couple really important factors for prediction. One, which isn't helpful if you haven't had one, but a previous history of hamstring injury. Right. And so that then is time dependent. The more recent it was, the more risky you are for another one. And then also, if you've had one, whether or not you've completed a progressive, staged, proper rehabilitation program to return to play is also a predictor. And so it's saying, like, if you just injure your hamstring, give it a couple weeks of rest and go back at it, this is dangerous.
Yeah. So you've got two factors at that point because, because you have a previous injury and you have, and maybe that's why also weakness probably fell to the lower level of things, or lower level of risk factors, is because, and this has always been a little bit of a pet peeve of mine in the literature that makes these risk factors a little bit hard to study, is if previous injury is a risk factor, you go, oh, well, there's nothing you can do about it. Well, wait a second here. Now we actually have some evidence that says high quality progressive rehabilitation probably mitigates the factor of something like weakness because it's no longer present. If you don't have a previous injury, if you don't have the high quality rehabilitation, or if you have high quality rehabilitation, you probably also mitigated the weakness.
Yeah, and this is where, I think it's a good opportunity to dig into muscle performance, right? Because weakness is just one construct of how muscles work, right? There's endurance, there's control, there's, power, there's a lot of different constructs for how muscles function. And, one of the preceding rationales for why hamstring injuries occur might be related to control, right? And control of the pelvis. Because as you change pelvic angles, you're changing hamstring length pretty significantly.
Absolutely.
And, it goes back to the first couple of weeks of PT school, we're learning length tension relationships, and that could be the thing that's compromising the hamstring. Also related to return to play, this guideline does a really good job of outlining what are the things that should be in there in terms of returning to play, right? So eccentric training, really important thing in return to play, right? And
absolutely.
And this is a really good guideline for you to be curious about and say, okay, return to play is an important thing. What is return to play? And it'll take you through all of those steps to understand what are those solid parts of a proper rehab program that reduces somebody's risk.
That's fantastic. And that's the crazy thing. I mean, what's really cool is you are putting together all of these different pieces of prediction, and risk factors and things like that. So we have risk factors for injury, but we need to know those so that we are removing those risk factors in our rehabilitation process. And this guideline goes through and says, these are the things that you should be doing, which I suspect those things that you should be doing relate to some of the risk factors.
Yeah, precisely. And especially the control part, right? You're talking about neuromuscular re-education to reduce your risk for re-injury, and that's a really important thing. And this neuromuscular control and re-education is sort of the link between this topic and my next topic.
Okay.
And the next topic I want to go through is that third revision of the plantar heel pain and plantar fasciitis. Okay. And this is good. This is a mature guideline now, right? Because it's been through 3 iterations, and it's fun to read it just on like a guideline author level, because you see the authors talking about what they talked about in the first guideline and then how it changed, right? And then when you read it, there's like, well, here's what we thought it was. The reality was in 2014. Now we're in 2023, and what's changed since then? And they'll give you that update. They'll start with like, here's what we thought, here's where we are. And it's just a really satisfying guideline to read. It points you through some really important things about night splints. There's real strong evidence for night splints, in particular for people who have first step pain in the morning.
Okay.
And body mass, right? So really addressing like holistically somebody's health with body mass. But then also this idea of neuromuscular control and neuromuscular re-education. So controlling loading through the hip and through the pelvis is really an important thing to do. And so that's really far from the foot, right?
Right.
And it talks about manual therapy and addressing lower chain impairments with manual therapy. And so you start to understand that, like, oh, maybe this plantar fasciitis, it didn't start here,
Right.
Maybe we have a collection of impairments that have led to this overstressing.
Yeah.
Of the foot.
What is the root cause versus what is the symptom, right? I still remember early in my career, that they even said with knee injuries is just the knee injuries are just is a consequence of poor function at the hip and ankle, and the knee is just the casualty that happens, right? And so
Yeah.
the foot is just the casualty of the entire chain, the entire body, back to neuromuscular control in the hamstring, back to, hey, if we're not controlling our pelvis, if we don't have good core stability, other things are going to have to compensate for that in order to, the body's going to function. The body is
It's finding a way. Yep.
Yeah, I mean, its design is unreal in that it is the consummate, compensator, right? There's no machine. Like, I wish my car could learn to compensate way better when it had one problem. Instead, it just shuts down.
It's
But
done.
no, the body keeps going.
Yeah, the body keeps going. Here's another thing which is interesting about this heel pain guideline. We don't often see evidence statements that say, don't do this.
Okay, what is the don't do? I got to hear this.
Yeah, well, first off, the reason we don't see evidence statements that say don't do this is because we don't want to have a guideline limit our scope, right? Guidelines are tools to give you a recipe for an ideal practice, but then still want you to be able to innovate and function and practice and maybe do those things that are important for patients.
For a particular individual
Yep.
in front of you, not just the general population.
But this one has a don't do statement, which is ultrasound. Don't do ultrasound.
All right.
No benefit.
That's good. It's been a minute since I've done an ultrasound.
Yeah. So I like to announce and applaud, and I make a cake every time I see it. So yeah. So don't do ultrasound for this. Although low level laser is maybe good for short term pain reduction. So if you're into the modalities, there's an option for you.
Absolutely.
Yeah. So good. Yeah. So that's a really fun guideline too. That's a good read.
That's awesome. So have we hit the high level on
We've hit them.
All right. So if we've hit the high level, how can we, can we go through some case scenarios? Because again, one of the goals of what we do here is not just to talk about the research, but how would I implement this into practice? Can you give some case scenarios? Can you give some how-tos, if you will?
Sure. Yeah, I was thinking about this, as I was reading the guidelines and preparing for the podcast, and I was thinking about, what are some moments where these things really resonated for me in my practice? And, interestingly, this is a point where I see like some of my residency and fellowship training really played well in my life. And then the guidelines have kind of come to meet that, which is kind of a neat thing. So,
right.
The first case is a patient that I saw who was referred to me for adhesive capsulitis. And they had right upper extremity adhesive capsulitis just sort of starting. And it was secondary to a distal radius fracture.
Oh.
And so this person had fallen, had a distal radius fracture, and they were going to OT for several months. And by the way, that distal radius fracture guideline recommends OT as one of the care providers that's appropriate for this, right? So So nothing about OT is bad for this. This is good. It's proper.
Right.
Our scopes of practice are slightly different though. Right. And so I would see this woman come into our clinic. She would go see the OT. And for probably 3 months, I saw her going to OT. And I was part of her care. I didn't pay too much attention. I just saw this woman come and go. And then suddenly she's in front of me for a shoulder examination. And so the first thing I wanted to do about adhesive capsulitis is understand, well, what are my boundaries about evaluating her shoulder with respect to the function of her hand? And she had, after 3 months of rehabilitation, basically no wrist extension. She was stuck here. And so accordingly had really weak grip strength and, was limited with function. And so I'm like, kind of going through the problem solving here. But the point of this case that I want to take away is that, one of the big scopes of practice differences between OT and PT is that PTs tend to use a lot more manual therapy, right? Mm-hmm. And as a manual therapy fellow, that's my lens. And so the first thing I started doing was doing sort of a joint mobility assessment on that wrist. And that's a thing in the guideline for this distal radius fracture, is that manual therapy can be applied to distal radius fractures specifically, depending on patient tolerance and fracture stability. Okay. And so this person, 3 months out, they're healed, right? The fracture is stable. And she was really tolerant of movement and doing things there. And so as I was doing some manual therapy, I did some traction to her like proximal carpal row. And boy, we had this click happen. And the click was kind of momentous. And, it's interesting because in the guideline, it talks about manual therapy being effective for short-term changes, which it most often is. In this case, it was a long-term change because we were sort of, I think, fixed something that might have gotten subluxed in the fall. And we were able to immediately achieve 30 degrees of wrist extension.
Oh,
and so,
fantastic.
I think not being afraid to use manual therapy after a fracture like that, even if you're not that familiar with the tiny bones, right? Like PTs sometimes are like, oh, distal upper extremity, you stay away from me a little bit.
Yeah,
but
I
really encourage people to know the anatomy and really dig into that. And then, this is a great case where the guideline gives you that confidence to be able to go in there and do a manual therapy assessment. And then right away, we were in a much better spot because then once her hand got functional, well, now she could start doing things and using her shoulder to try to mitigate the progression of that adhesive capsulitis.
That's awesome. Do you have another one?
Yeah, I do. I was thinking about the plantar heel pain, the plantar fasciitis. And so I was seeing a patient. She was about 65 years old, definitely overweight and deconditioned, not very athletic person. And they had been being seen at a different clinic. I think a podiatrist had sent them somewhere. And this person was getting a really robust program of foot stretching, like gastrocsoleus stretching. I think they were getting their ultrasound and they were really having some trouble. And they were also got some footwear modification. And so footwear modification, that's like saying one thing, but meaning 1,000.
Right.
And so
it could be everything from high quality custom orthotics to, I put a piece of paper in your shoe.
Yeah. So what she had was these rocker bottom shoes, right? Really cushiony, really rocker bottom shoes. And now you're talking about somebody who doesn't have really good balance. Okay.
Right.
And so in this case, that was sort of the first thing I saw was this unstable person walking through the door into the clinic with these rocker shoes. And, the idea was to give them cushioning, right? A heel cushion or some support. And that's good, right? That's supported in the guideline. But then the other part of this that we were talking about is this neuromuscular control and the stability. And so it was an opportunity for me because she had already done all of the intrinsic foot strengthening that's recommended. She had already done the stretching, the windlass stretch. She was, massaging all the modalities we could think of. And so that wasn't the thing that was changing her. And so let's look at the balance. And the balance was predictably poor. Single limb support was poor. Any dynamic balance was poor. And so, I talked her into coming to PT without the rocker bottom shoes. And we did PT with that stability. We did some hip stretching. We did a lot of hip strengthening and control. I remember, the first time we got into like a half kneeling position, this person, maybe hadn't been in that position for 40 years.
Right.
And it was a new spot. Right. And, but that learning over time suddenly, it took a couple weeks to maybe 3 weeks to start seeing those changes because it had been really persistent. But that was something that, really changed her outcome really, really quickly was that hip control and hip stability. Right. And before I present myself as this like, oh, I can fix everything kind of thing. Well, I missed something,
What do you
right?
miss?
I had a bias against night splints. I'm like, things, that seems complicated. I don't like it. Now that I read the guideline, there's strong evidence for this, right? And so I might have,
Maybe her outcomes could have been better faster.
yes, I missed that, right? And so now if I'm going back and seeing that same person again, I'm probably prescribing a night splint for 1 to 3 months at the front end to see if we can't improve that even sooner.
Well, what I like about the guideline that you said about night splints is, one of the things I'm really big on is matching impairment, matching your manual therapy to an impairment and retesting, matching an exercise to an impairment and retesting immediately. But what I heard in that I'd never heard before is matching the intervention to the what I would call impairment. It's a symptom, of first step in the morning pain. That a night splint, if that first step in the morning pain is present there, then a night splint is even more recommended. Is that
Yeah, that's exactly
right?
the statement out of the guideline, right? So that's the thing that connects you to that night splint is that first step pain, because not everybody has that, with plantar fasciitis. So
For sure, that's incredible. And I see when we're looking at here, you just gave two examples, literally from the extremes of the body, the extremities of the body, right? So we have a distal radius fracture and plantar fasciitis at both ends. Do you know what connects both of those? Balance, right?
balance.
And testing balance, and then identifying where in the balance chain the problem is. Is it in the hip? Is it in the hip stability that we need to get them into half kneeling, or is it in their core stability? Where does that live? And so I think that's what we almost opened up this episode with. Is the neat thing is when you look at these different rehab guidelines, you can see these overlaps and go, oh, maybe I need a global systematic approach to be able to look at these things in a way that lets me treat the whole person, which is what we really want to do.
Yeah, it's such a simple thing, but you gain so much information when somebody stands up out of the chair and they walk into your clinic,
Yes.
right? And you just watch them move, and just that you're not doing a test, you're not doing a thing, you're just getting the sense of how somebody moves through their life, and that's the core of what we do is look at movement. So that's what makes us unique as providers, whether you're an OT or an athletic trainer or a PT. You're focused on a very unique way to solve problems through movement, which is very satisfying.
That's fantastic. All right. So talking maximum impact, what are the top 3 takeaways that we can put into practice right away?
So I think all of the little subtle points of the evidence or the statements from the guidelines, right away, that's too big to say these are our top 3 takeaways. But I think the top 3
you just told me you
takeaway.
didn't like my question.
Yeah, no, I love your question. I love your
Okay,
question.
good.
I think I can answer it poorly, really quickly, right? But so the first takeaway I think is about how to use the clinical practice guidelines, right? So try to learn how to consume these really large documents piece by piece. Use that evidence statements and the summary at the beginning. Some of them, like I know for sure the Net Clinical Practice Guideline has an accompaniment publication, which is just a visual graphic summary of the guideline. It'll take you through diagnostic classifications and through. So there are tools built into the guidelines to help you consume these really big documents. As a matter of fact, some of the newer ones even have the strategy for implementation, and they will talk about the tools that they have to help implement the guidelines in it.
Oh, fantastic.
Yeah. So I think that's a good one. I think the other thing we said that to me has a lot of takeaway here is don't look at an exam prep course as just an exam prep course, right? Look at it as a broad overview of contemporary practice. And so think of it as an avenue for professional development. And I think, that changes the goal a little bit from external reward to this internal reward. And I think that's really, really a nice thing to think about. I guess maybe the last one would be a reflection about what I did personally to prepare for this session, which is here's all the field of physical therapy and orthopedics and sports. And, how do I pick the things? Like, how are those top 5 things? And I tried to get 5. I think we ended up with 10 or 12 or 13. But, ask yourself, what are these contemporary updates? And let the guidelines be your guide to understand that. Let that curiosity that you have, like ask yourself that question And if you ask yourself that question like once every 3 months or so, hey, what's new? Just do a quick lit search. Go check out the guidelines. Let that curiosity be a stimulus or a catalyst for you to like learn a new thing or two. And as you're doing it, you get this nice feeling inside, like, hey, I think I'm a little better with my terminology about acetabular version right now.
Right.
I feel like I'm a pretty cool guy right now. Maybe need some new
That's awesome.
sunglasses.
Well, and I love the idea of, clinical practice guidelines are now, maybe 15 years ago, it was like one new one every 3 years, it felt like. And now it seems that they're coming out rather sequentially and, like you say, being updated. And so we could almost even just, if we make a quarterly habit of looking at the new ones or one we haven't gone into or want to go into more, that is going to advance our practice.
Yeah, and I mean, if you're talking like anywhere from 25 to 90 or more pages of guideline, there's always going to be some things in there for you to read. So
absolutely,
it's a really nice curated form of evidence for clinicians, I think, to utilize and let the nerdy people that get paid to be in the weeds about the nerds, you let them worry about the intention to treat analysis for the study. So
that's fantastic. That's great. All right, so to wrap things up here, what are you currently working on or learning?
Yeah, so thanks. I'm working on, as always, I'm building some new hybrid programs and I'm teaching some stuff and working on those kind of things. But what I'm really excited about is I'm launching a new podcast. And so it's going to come out in the next week or so, and I'm going to call it PT Outcast. And so that's an interesting name, but the tagline is going to be, come think outside the box with us.
Oh, that's awesome.
Yeah, and it comes from this joke once at a Graham session, and people might not know what Graham sessions is, but it's sort of like a discussion panel, right? So a lot of people, leaders in the profession, get together and they talk about some topics that maybe need debate in our profession. And there was this idea that people were off the island sometimes in physical therapy. And what that meant was you might be a physical therapist, but say maybe you go work for like Medicare and Medicaid services. Mm-hmm. And you're still a PT, right? You're still doing your thing, but in a much different, you're not in a clinical practice setting. And we had this tendency in the profession that if you weren't doing clinical practice, you're off the island.
Wow.
Right. And so it was devaluing some of these people that were trying to expand the scope of what our profession is and where we can have influence. And so they felt like they're outcasts off the island. And so that it's a little play, like think outside the box. It's okay to be off the island.
Think about all the different things you can do. Oh, that's fantastic. And maybe shed a little bit of light on that and how those things can inform clinical practice, actually, not necessarily take away from.
Yeah. And so the first guest is going to be Cornelia Kulig, which is fantastic. She's one of the founders of the FAAOMPT, the Manual Therapy Academy. She's a full professor at USC. And she also gave this really great Malley lecture about 10 years ago where she talked about residency in every neighborhood. And it's been 10 years and there's not residency in every neighborhood.
Right.
So we're going to talk about, well, what happened?
I love it. Yeah. Well, I love not being afraid of the issues too. So that's fantastic. How can people connect with you? What's the best way to connect with you?
Yeah. I get most satisfied when people connect to me through Instagram mostly, right? That's my favorite platform, which is I'm just Eric Robertson, no spaces. All my socials are just at Eric Robertson. So you can find me Facebook that way. You can find me on the thing that is Twitter. Or X or whatever you want to call that thing. So find me there. And then, you'll be able to, it's just launching this content, but ptoutcast.com, or, at ptoutcast on Instagram. And then finally, just my artistic website, which is, ericrobertson.com. And there you can go and see my photos and, my link to photos and physical therapy has a lot to do with environmental physiotherapy. Right. There's this using art to understand lived experience and the world around us and to question our relationship with the earth, as we also need to prepare providers to treat people with climate change related illness and conditions.
That's fantastic. Well, that sounds amazing. So tons of different ways to connect with you. I love it. If you'd like to connect with me, find out what I'm learning, what I'm doing, what I'm up to, certainly you can do that at philplisky.com and the different social handles. Well, that's all the time we have today. Thanks again, Eric, for the insight and clinical takeaways related to the broad field of orthopedics. I know it was a big topic, but so glad you could join us.
Yeah, thanks, Phil. It's always a pleasure to talk with you. I feel like it's been too long since we got to hang out and talk, and we're not next to each other, but we're next to each other here. So it was really enjoyable. I appreciate it.
Yeah, it absolutely is. It's one of my favorite things. Well, fantastic. Until next time, let's keep building the future of rehabilitation and performance together.
Thank you for tuning into this episode of Rehab and Performance Lab by MedBridge. Please be sure to subscribe and listen to more of our episodes on Spotify or your favorite podcast platform and at medbridge.com. If you're listening outside of the MedBridge catalog and would like to access the bonus resources and receive continuing education credit, simply log into your MedBridge account and search for this episode to find the accreditation details. Rehab and Performance Lab also listens to you. If there's a particular clinician that you'd like to hear from, or if you have a clinical question or a challenge that you would like to see addressed on this podcast, please let us know by leaving a comment on our Instagram posts or by emailing podcast@medbridge.com. See you next time.